crazy.
Hello, everybody. Welcome back to Hot Topics in Neonatology. We are joined by our good friend, Dr. Lindsey Knake from the University of Iowa. Lindsey, welcome back.
Thank you. I'm so excited to be back. You know, I was on one of the first episodes when we were doing the board study review stuff, and I thought
hosted.
And I thought everybody forgot about those episodes. And then I presented at a fellows conference, and they're like, "We know you," and I was like, "Oh, I'm famous."
That's so cool. That's so cool.
People still listen.
We were talking off air about the fact that you came to Hot Topics with your 4-month-old.
Yeah.
Can you tell us a little bit about what is it like to come with a child to a medical conference?
Can it be done?
It can be done. You need a good support system, as is everyone in medicine. You know, we get in medicine and we have kids because we have a support system. So actually, my second child, my 4-month-old, is very well traveled already. Don't tell any of my pediatrician friends, but she did get her RSV vaccine, so it's okay. But you know, it's hard because you get invited to present at these conferences, and you still want to go and you still want to advance your career, but you don't want to miss out on your family. So the fellows conference I told you guys about, I actually brought my 3-year-old and my 4-month-old and my husband. It was on the beach, so I was like, "Hey, beach vacation, except I'm working." But then my husband got burnt out. I don't know why. So this time around, it's my mom who's come with the free trip.
I love that. I love recruiting the rest of your village. I've done that a number of times. My daughter's school-aged now, but she's been a conference travel for quite some time. And now actually she really enjoys it. She likes to come to lectures, actually, and hear what we're talking about, which is really, really
That's
cool.
so cool.
But I think starting them young, as they say, is important.
My daughter this morning was like, "You're going to DC?"
Why didn't you
She's
take
like,
me?
I would have come. I'm like, "You're going to school. What exactly do you mean?"
Obviously, she would have come.
They love that. Well, good for you.
Yeah.
I think that's so important. And you participated in the big quality conference. It was a full-day conference yesterday as a prelim to the Hot Topics 3-day conference moving forward. So tell us what the takeaways are about QI and AI.
So it's really cool because I don't really consider myself that much of a QI researcher, although I do a lot of electronic health record interventions, which could be QI, could be research. It's really all about how you spin it. But that's what we talked about yesterday was, you know, my piece was talking about how can we use clinical decision support and implement things into the EHR for when you're doing QI. My mantra at the University of Iowa is if you have a new protocol, do you have an order set to go with it? Or no one's going to pay attention to your protocol. So that was, and some of it's funny because some of the other researchers did presentations where they showed their run chart and they're like, and then we implemented the order set and the run chart went up, right? So, and that's where EHRs and technology is really integrated into QI, and you have to think about it. Maybe not in your first PDSA cycles as you're figuring things out, but eventually getting it in there. And then I also went through the 5 rights of clinical decision support, which is, you know, as an informaticist, what you think about when you're implementing these things. Are you getting it to the right person? Biggest thing is at the right time in their workflow, because many of us want to snooze all those alerts. And, you know, are you doing it in the right format, right information? You know, all those sorts of things you're thinking about in QI anyway, but you can actually formalize it and look through those things.
And you're saying the EHR can help us with that being on time with our interventions.
I was going to ask you, it feels like there's competing interests because on the one hand, I think we're all terrified of touching the EMR because people have gotten their rhythm. Like if I mess up their rhythm and it's not the right version, then I'm going to get such backlash. But on the other hand, like you said, until you sort of formalize this and incorporate it into the work structure, then it has a harder time getting off the ground. So how do you pick the right time where you say, all right, maybe we'll have to do 1 or 2 tweaks down the road, but still this is the right time to go into the EHR and just try to change the order set?
And it depends on your system a little bit and how many resources you have to do multiple PDSA cycles of let me tweak this order set or let me tweak this. You know, if you don't have many resources, it's like give me the perfect version and then we'll try to go live. But we're never good at getting the perfect version, right? We're probably going to have to change things down the road. So I think it's just talking with your health system about kind of the thought and how fast you can get it in. Sometimes it is a long waiting process and you're not going to get it into the EHR until you're to the end of your PDSA cycles anyway, if you submit your request in the beginning. So it's balancing that.
And I'll say I'm the person on the team who's like, I want to do the protocol. I can't wrap my mind around it until you make an order set. And I don't miss any of the pieces.
Right.
Yeah, but on the other hand, you're also the person just like me, like, I didn't know there was an order set for that, right? And
it's balancing it. You want to. One of my slides is don't overdo your clinical decision support, and then everybody's going to forget about it as well.
Yeah, because you don't. Yeah, I mean that's the key as well. how is the implementation of AI tools in the NICU? I mean, we've been talking a lot about this, and it seems like we've reached a point where there's a bit of a taboo where we're not really supposed to use these AI tools yet, but pretty much patients, doctors, everybody's using it.
So my favorite from the QI takeaway yesterday was Dr. Beam showed how to do QI in 2.5 minutes with ChatGPT, and I was like, oh my goodness, I needed this as a fellow when I needed to do my QI project in the twilight hour.
It gives you a good skeleton.
It does, right? So you're not putting in PHI, patient information, because that's a big thing about can't use ChatGPT or some of those large language models with HIPAA information yet, unless your system has a lockdown safe version of it. But you can put in, hey, I want to make a QI project for this. And they're like, well, let's make it into a smart aim. And it gives you like all the different steps. Yeah. And it even spit out a skeleton checklist or protocol you can go through. And then it gives you something to edit and start from. And that's the whole point of these large language models, is to improve efficiency of getting you a starting point of something that you can read, make sure it's correct, edit, and iterate on.
I always say it's kind of like having a team of 5 interns, basically, because it'll do a lot of the grunt.
Not like medical interns. You mean like?
Oh no, like interns. I'm sorry, like interns. I'm sorry, like interns at a company.
That's right.
But like they'll do like
or medical students.
Yeah, but I'm saying they'll do a lot of the work. They'll do the work that you're not really excited to do, but it will start, and it may not be perfect, but it will get you forward. Yeah. So it's really helpful, and I think it's important what you said, that like we cannot put in PHI. I think people don't really realize that if you were to put in PHI, it goes into the training data set of like OpenAI, and like it could spit out I've heard about this where it could spit out the PHI to another user who says, tell me a sad story of a baby having a hard time, and it might spit out your story of your patient in the ICU.
Right. So you don't want that.
You don't want that. That's not good. That would not be good. That's all sorts of violation.
But all the administrative tasks you do, it can really help us out. You know, I do it for writing emails. How do I make my emails more empathetic than I am? You know, AI can be really good at that. How to write letters of recommendation.
I should not say what all the...
Minor. Can you make mine less empathic? I really need to be a little bit more stern in this email.
I literally use ChatGPT and say, this issue really upsets me.
Yeah.
So here's what's on my mind. Can you draft a composed email so that I don't sound in any way either? Because I mean, it's been very helpful.
That's great.
Yeah.
You mentioned something else in passing, but so how can the EMR and AI help us then track our QI work?
So some of those tools are built into your EHR. So we have Epic at the University of Iowa. So I encourage people to first start using the tools you have. So Epic has Reporting Workbench, it has Slicer Dicer. You can build custom dashboards. So trying to use what's already in the EHR is helpful. But then some of what we talked about yesterday is there are third-party systems you could use, but then that just takes finances and time and getting them implemented. So I think more and more is coming that we can more easily access our data, and the tools are getting better. And large language models are going to start being implemented into the EHR soon, so it'll be exciting to see where that's going to go in the future as well.
Yeah, there's a lot of these companies, these startups are raising a ton of capital, and you can tell that it's going to start flooding our units and our hospitals for sure.
Really exciting to see where things are going to go in the future. We're piloting a lot of stuff at Iowa, so it'll be fun.
Lindsey, before you head out, anything you're excited about at Hot Topics this year that you're particularly saying, oh man, I'm excited about this session?
So I was...
Aside from yours.
It's obviously mine, but now mine's over. So now I just get to enjoy. But honestly, this first day of Hot Topics, I think has been the best one yet that I've ever gone to. I felt like it was like made for me because it's all about respiratory stuff, about cool technology. And then the last session is about AI, which, will obviously I like. And Dr. Beam and Dr. Sullivan are going to kind of give their research aspect. But it's really cool. One of the things that they showed at the first session was the EIT. Did you guys see that about the respiratory belt that you can put on neonates, where it's actually showing optimal PEEP and optimal lung expansion for some of our neonates? Right? Cool. We've been imagining this and thinking about this for years. Go up on the PEEP, go down on the PEEP. Like maybe we need some more PIP,
I actually think it's like sci-fi. It's like beyond. I think what we thought could be done with that side. Yeah. So it's super cool.
You don't have to go inside anymore.
That's right.
Yeah. So as somebody who thinks about big data and waveforms. I'm just really excited about maybe getting more of these respiratory belts on our babies in the future, and then it'll tell us, hey, before that FiO2 goes up to 50 or 60%, I'm going to alarm you that your lungs are collapsing or you got a pneumothorax coming, and think about interventions.
Yeah,
So
revolutionary.
don't win that peep and let the kid just put Absolutely. Lindsey, thank you so much for dropping by. Congratulations again on your work, and we'll see you around the conference.
sounds great.
Thank you.